Hi future nurses, your nurse here. Welcome back to Scrub and Spoon. How are you all doing? Okay, so today's Nclex review is on the dreaded IV fluids. We are talking about the hypertonic fluids, the isotonic fluids, and the hypotonic fluids. So stay tuned. There is a lot to learn in this review. Okay, and if you love my teaching, you will love my master message flashcards that contains the 11 body systems taught in nursing school and over 120 Nclex most tested disorders. So do well to check my website out, and there's a link in my bio. Okay, now without wasting too much of our time, let's go. The first question says, a patient with severe hyponatremia, which is 118, right, is admitted with confusion and seizure. Which IV fluid order should the nurse expect? A, 0.9% normal saline. B, 3% normal saline. C, D5W, and D, lactate ringers. And what is your answer? And guys, the right answer is B, 3% normal saline. Now let me explain it to you. I want you to understand what is happening here. The patient have severe low sodium, okay? And that severe low sodium is already affecting their neuro status. Look, they're already having confusion and seizure. Those are neuro symptoms, okay? And why are we giving them 3% normal saline? Because 3% normal saline is an hypertonic fluid. And what does that mean? Hypertonic fluid means the fluids contain high salt, less water concentration level. They have low sodium. So you want to give them fluids that will quickly correct the sodium level, which is an hypertonic fluid, and that's why we're giving them 3% normal saline. I made a video on how to identify all these types of IV fluids. If they're hypertonic, if they're isotonic, if they're hypotonic, go review that so you can understand this. Okay, so and for hypertonic fluids, I want you to know that they pull out water from the cell and cause the cell to shrink. Okay, so you want to infuse it slowly, and you want to infuse this hypertonic fluids through the central line, because hypertonic fluids are very harsh on the vein. So you are not do not infuse it through the peripheral line. You are infusing through the central line. Okay, and why are you infusing it slowly? Like I've explained, they pull out water from the cell and cause the cell to shrink. And look what the patient's already having. The patient already have confusion and seizure, which means there's some level of cerebral edema going on. And so if you give them hypertonic fluids, these fluids will help to pull out, when you infuse it slowly, it will help to pull out the fluids from the brain cell slowly, right? And that will help to correct the neuro symptoms that you are seeing here, the confusion and the seizure. Okay? And like I said, that hypertonic fluids, they contain high salt. And what we really want to correct is the salt level. Is the salt level that is low. So if you give them hypertonic fluids, that will help to pull out water from the swollen brain cell and put this water back into the bloodstream. This will help to correct the serum sodium and reduce cerebral edema, because it is cerebral edema that is causing the confusion and the seizure they are experiencing. So let's go through the wrong choices. A says 0.9 normal saline. This is wrong. 0.9 normal saline is an isotonic fluid, and this fluid, it means that these fluids contain equal amount of salt and water, but we want a fluid that contains high salt so that it can quickly correct the hyponatremia. Okay, so in severe hyponatremia, 0.9 sodium chloride normal saline will not be useful to correct hyponatremia. And C says D5W, that is 5% dextrose in water. Remember, dextrose is sugar, right? And is something interesting about 5% dextrose in water is, in the bag, it is an isotonic fluid. And when 5% dextrose in water metabolizes in the body, it turns to hypotonic fluids. And hypotonic fluids push water or shift water into the cell. So if you should give them these fluids, 5% dextrose in water, it will shift more water into the already swollen brain cell, which is why they were having the confusion and seizure. Right? Because hypotonic fluids shift water into the brain cell and cause the brain to swell up like a hippo. So hypo cause the brain to swell cause the cell to swell like a hippo. Okay, and it will also worsen the hyponatremia because it is free water, it is the excess water. It will dilute the sodium more, but that's not what we want. We want a fluid that will cause the sodium to rise quickly, that will correct the sodium. Okay, so that's why that is wrong. And the last one is lactate ringers. Lactate ringer is also isotonic fluids, and it contains some electrolytes, but it does not correct sodium level. It is not used to correct hyponatremia, and that is why that is wrong. Okay, let's move on. Now the next question says, a patient in diabetic ketoacidosis has a serum sodium of 148 and glucose of 510. Which IV fluid is most appropriate? A, 0.45 normal saline percent normal saline, B, 0.9% normal saline, D5NS normal saline, and D, D10W. Okay, guys, and the right answer is B, 0.9% normal saline, which is an isotonic fluid. Now, guys, let's explain what's going on here. Your patients have DK, diabetic ketoacidosis, and in diabetic ketoacidosis, patients will experience dehydration. They will experience hyperglycemia, and that is why you see the blood glucose is 510, because DKA is a life-threatening complication of type 1 diabetes, because there is not enough insulin to drive or to shift blood glucose into the cell. Now listen to this. Insulin is used to shift the sugar that is in the blood, to shift it into the cell. Now there is not enough insulin to shift this sugar into the cell. Now this sugar is staying in the blood. Now there is accumulation of sugar in the blood, and that is blood sugar. Okay, so the sugar is too much in the blood that is already causing the blood to mold up, to clump up, right? Now the kidney says, how can I help the blood get rid of some sugar? And that's when kidney says, okay, if I cause the body to pee more, they will pee out some sugar. And that's when osmotic diuresis comes in, so that the patient can get rid of some sugar that is in the blood. But this is the twist. As the patient is peeing a lot, and that's why they are dehydrated, because they are peeing a lot. Truly, as they are peeing a lot, they are peeing out sugar, but they are also peeing out some other stuff. They are peeing out potassium. Okay, so the kidney wants to help the blood to lose some sugar, but think about the sugar as water magnets. As the sugar is leaving the body through the urine, potassium is also leaving, and that is why dehydration comes in. Okay, they are dehydrated because of osmotic diuresis, losing so much fluids. Okay, and DKA, our priority is fluid volume resuscitation to prevent circulatory collapse. So if we should give them 0.9 normal saline, which is an isotonic fluid, that is, this fluid stays in the vessel, in the intravascular space. This will help to expand circulatory volume quickly, and that is what we want. They are dehydrated, fluid resuscitation, and that is why we are using 0.9 normal saline. Now let's move to the wrong. Now let's do the wrong ones. A says 0.45 normal saline, which is half saline. Half saline is hypotonic fluid, and it is not the initial fluid you will use in DKA. You can later use half saline after the initial fluid resuscitation, especially if sodium is elevated. In this situation, the patient's sodium is slightly elevated. So after the fluid volume is back to normal, because they were dehydrated because of peeing a lot. Now after you've corrected the fluid volume, then we can use 0.45 normal saline, which is half saline. Especially if you see that the patient's sodium is slightly high, then you can use this, because this provides free water, and it can help to dilute the sodium and bring the sodium to the normal range, because normal sodium is 135 to 145. This is 148, it's slightly high. Okay, and C says 5% dextrose in normal saline. Guys, 5% dextrose in normal saline. Dextrose is sugar. This is sugar in normal saline, and the patient is already hyperglycemic. Why would you want to give them more sugar? Okay, no, this should not be your initial fluid to use to correct, because we are looking for we are trying to bring down the blood glucose and correct the circulatory volume. And after the blood glucose has been corrected with insulin, right? It's insulin that will bring down the hyperglycemia, right? Then later on, when the blood glucose drops to around 250, you can add dextrose, because the insulin is still going on, right? You can add dextrose, and this will help to prevent hypoglycemia. But it's not the initial fluids you will use, because they are already at 510 hyperglycemic. The first thing is to you want to lower the blood glucose with insulin, and then once it drops to somewhere around 250 to prevent hypoglycemia, then you can add dextrose later. So it's not the initial fluids, because the question says initial fluids. Okay, and D says 10% dextrose in water. This is pure sugar water. It will worsen hyperglycemia and dehydration. This should not be your initial fluid because it's like you're adding more sugar to the already elevated sugar level, hyperglycemia. Okay, and it is not appropriate in initial phase of decay. Okay, now the next question says, the nurse is caring for a patient with increased intracranial pressure, ICP, after head trauma. Which IV fluids are appropriate? This is select all that apply. A, 3% normal saline. B, 0.9% normal saline. D, D5, C, D5W. D, 0.45 normal saline. And E, mannitol. Guys, since it's all select all that apply, let's go through it together. Now, let's go through the first one. A, 3% normal saline. Absolutely yes. Why? Because 3% normal saline is hypertonic. I've been explaining this, and they help to pull out water from the cell. Look, this patient have increased intracranial pressure. So if you should give them 3% normal saline, it will help to pull out water from the swollen brain cell into the bloodstream and reduce cerebral edema, because they're having increased intracranial pressure. There is increased pressure in the brain. So if you should give them 3% normal saline, it will help to pull out some fluid from the brain cell, and that will help to reduce the cerebral edema and the intracranial pressure. Okay, and remember, when you're giving hypertonic fluids, like I've been saying, it is given through the central line and it is infused slowly. I've said it before. Okay, and the next one, B, says 0.9 normal saline. Absolutely yes. Why? Because this is an isotonic fluid, and what do? This fluid stays in the intravascular space. They do not shift into the cell because the patient already have intracranial pressure. So you don't want to give them something that will increase the pressure in the brain or cause cerebral edema. So 0.9 normal saline is good because this fluid stays in the intravascular volume without shifting water into the cell. It will not shift water into the brain cell. Okay, so and that is why that is good. So 0.9% normal saline is safe for patients that have increased intracranial pressure, ICP. It doesn't worsen the cerebral edema. Okay, C says 5% dextrose in water. No, like I have been saying, that 5% dextrose in water is isotonic in the back, but when it is metabolized in the body, it turns to hypotonic fluids. And what happens with hypotonic fluids? Hypotonic fluids shift water into the cell and cause the cell to swell like a hippo. They have intracranial pressure, some fluids in the brain, some edema in the brain. You don't want to give them hypotonic fluids that will shift more hypotonic fluids, that will shift more water into the brain cell and cause more neuro impairments or neuro symptoms like confusion, like headache, like seizure even. So that is why we are not giving 5% dextrose in water. It provides free water once the sugar is metabolized. Okay, and will cause cerebral edema. That's why we are not giving them. Okay, and D, 0.45 normal saline. 0.45 normal saline is still hypotonic fluids. We do not want to cause more cerebral edema, cause more intracranial pressure in the brain, because these fluids have normal saline will shift more water into the brain cell, and we don't want that. And that's why we're not giving them. E says mannitol, which is osmotic diuretic. It is good. This is good because it creates osmotic gradients. It pulls out water from the brain tissue into the bloodstream, and that is what we want. Okay, I want you guys to go watch that video so that you can understand everything I'm saying. And because the question says the patient have ICP, when the patient have ICP, maybe it's due to some head trauma. The pressure in the skull, in the head, is high. And giving this fluid will help. This fluid will help to pull some fluids out of the brain cell. Okay, now let's move on. A patient with burns covering 35% TBSA, total body surface area, is admitted. Which IV fluid should the nurse expect for initial fluid resuscitation? A, lactate ringers. B, 0.45 normal saline. C, D5LR, and D, 3% normal saline. Guys, and the right answer is A, lactate ringers. Why? First off, lactate ringers is isotonic fluids, and it is preferred fluid for burn resuscitation. And you know, isotonic fluid stays in the intravascular space, expanding circulatory volume. Patients with burns are already hypovolumic, they've lost some fluids, and you want to replace that. And also, lactate ringer contains some electrolytes. It contains calcium, sodium, chloride, potassium, and lactate itself. And this will help to replace some loss of electrolyte. And lactate ringer, like I said, it contains lactate, right? Which is converted to bicarbonate in the liver. This will help to buffer metabolic acidosis in bones, because metabolic acidosis is common in bones, right? So this is why this fluid is appropriate for them. Let's go through the wrong ones. B, 0.45 normal saline. This is hypotonic fluids. These patients that have experienced burns, they need fluids in the intravascular space because they are already hypovolemic, because they lost blood, they lost electrolyte and everything. If you should give them hypotonic fluids, this, instead of this fluid staying in the intravascular space in the vessel, it will shift into the cell, and that's not what we want. This will cause storage spacing because the capillaries are already leaking. So it is not safe within the first 24 hours in burns. And C says 5% dextrose in lactate ringer. Like I've been saying, that 5% dextrose it becomes hypotonic in the body when it's metabolized. And you know about hypotonic fluids shifting fluid into the cell, and that is not what we want. We want a fluid that will stay in the vessel, in the intravascular space, to help the loss of fluids. Now let's go. A patient with end-stage renal failure is admitted with pulmonary edema. Which IV fluid should the nurse question in if ordered? A, 0.9 normal saline. B, lactate ringers. C, D5W. D, 3% normal saline. And E, 0.45 normal saline. So this question is asking that which of these fluids should you question if it is ordered in patients with renal failure? So which of this should you question? And guys, the right answer is you should question all the fluids. So you should question A, B, C, D, E. Now let's go. Let me explain why you should question all. Let's go into each. The first one, A says 0.9 normal saline. You have to question this order. Why? Because 0.9 normal saline expand intravascular volume, and this will worsen pulmonary edema. Look at the question. The question says a patient with end-stage renal failure with pulmonary edema. Okay, that is why you will question that, because it will worsen pulmonary edema. And you know that 0.9 normal saline is sodium chloride. So if you should give extra sodium, the failing kidneys cannot excrete the sodium, and this will lead to fluid retention. Okay, and that's why A is wrong. B, lactate ringer. Remember, lactate ringer contains some electrolyte like sodium and potassium, and they're already having kidney failure. In patients with kidney failure, it is hard for them to excrete potassium, and this will lead to accumulation of potassium in the blood if they're already at end stage. The question says they are in end-stage kidney renal failure. So it's hard for them to excrete the potassium out. So this will lead to accumulation of potassium in the body, and that will lead to hyperkalemia, lead to cardiac arrhythmias or dysrhythmias. And that's why that is wrong. And C, D5W, this is 5% dextrose in water, which turns to hypotonic fluid. It's isotonic in the bag, but hypotonic when it's metabolized in the body. This patient is already having pulmonary edema. This patient, let me say, have pulmonary edema. So if you should give them hypotonic fluids, because this 5% dextrose in water turns into hypotonic fluids in the body, it will worsen pulmonary edema. It will shift more fluids into the lungs, pulmonary edema. And we don't want that. And that's why we'll question that in patients that already have pulmonary edema. It will cause fluid overload. D says 3% normal saline, which is hypertonic fluids. Hypertonic fluids contain high salt, less water concentration level, and high sodium load cannot be excreted in patients with renal failure. Okay, these IV fluids contain very high salt, and they already have kidney failure. The kidney might not be able to excrete the sodium out, end stage, and that's why we question that. And remember, you can use 3% normal saline in patients that have low sodium, hyponatremia. Now the last one is E, 0.45 normal saline, which is half saline, and it is an hypotonic fluid, which will cause more fluid to shift into the cell. They already have pulmonary edema. You don't want that. It will lead to more fluids in the lungs. It will worsen the pulmonary edema. We don't want that, and that's why we are not using E. So we are questioning all of this. Okay, now let's go to the next one. A patient with SIADH, syndrome of inappropriate antidiuretic hormone, has sodium of 118, severe hyponatremia. plus neuro symptoms like headache, confusion, and vomiting. Which IV fluid is most appropriate to begin under ICU monitoring? A, 0.9% normal saline, B, 3% normal saline, C, D5W, and D, 0.45 normal saline. Now guys, I want you to understand what's going on here. The patient is presented with syndrome of inappropriate antidiuretic hormone, which means the patient is retaining so much water and losing sodium, because in SIADH, the kidney controls how much water the body loses. The kidney controls how much of water is lost in the body. Okay, so the kidney is retaining so much water, but it's losing sodium in SIADH. Okay, that is why they have severe hyponatremia, low sodium. And it is the low sodium that is causing the neuro symptoms that you are seeing: confusion, headache, vomiting. So the right answer will be to give them B, 3% normal saline. Why? 3% normal saline is an hypertonic fluid. It means these fluids contain high sodium, less water concentration, and they are already hyponatremic. They are having severe hyponatremia, severe enough to cause neuro symptoms. So if you should give them hypertonic fluids, it will help to correct the hyponatremia immediately, because these fluids have high salt. And this hypertonic fluid will help to pull water out of the brain cell, and that will help to relieve the neuro signs and symptoms they are having. The confusion, let me see the symptoms they're experiencing, the confusion, the headache, because that is showing some presence of cerebral edema. So hypertonic fluid will help to pull out those fluids out of the brain cell slowly. You have to infuse it slowly through the central line. Okay, and that's why that answer is right. Now let's go through the wrong one. 0.9% normal saline. That seems logical, but in SIADH, the kidney retain water, not sodium. Remember, 0.9 normal saline is equal amounts of salt and water. So if you should give them in SIADH, the kidney will retain the water and do what? And excrete the salt. And you know, they have low sodium. So you need a fluid that have high sodium to correct the low sodium level they are experiencing. But if you give them normal saline have equal salt and water level. So the kidney will retain the water and excrete the salt. In hypertonic, the kidney will retain the water, but it will not excrete all the salt because the salt is very high, and that will help to correct the hyponatremia. And C says 5% dextrose in water. It is hypotonic when 5% dextrose in water is hypotonic when it's metabolized. This will shift more water into the brain cell. They're already having cerebral edema, and that's why they're having the confusion, the headache. You don't want to give them hypotonic fluids. And you know, hypotonic fluids contain less salt, more water. That means they will be retaining even more water, and the water will be diluting the salt even more. Okay, and that's why we didn't choose that. And the last one is 0.45 normal saline, half saline. It is also hypotonic, and it will do the same thing. It will dilute the salt more. The kidney will cause the body to retain even more water, and we don't want that. Okay, and that is why the best answer is that 3% normal saline, because it contains high salt, and it will help to correct the severe hyponatremia they're having, because normal sodium level is 135 to 145. This is 118. It's low. Now let's go. A patient with traumatic brain injury has orders of maintenance fluids. Which order should the nurse question? A, D5W at 100 ml per hour. B, 0.45 normal saline at 75 ml per hour. C, 0.9 normal saline at 75 ml per hour. And D, 3% normal saline at 30 ml per hour. And this is a select order apply question, right? Now let's go through it. This patient, they have brain injury, TBI. Okay? In TBI, the brain is swollen, which will lead to increased intracranial pressure. Because I want you to understand why you should choose the fluid we're about to choose, right? The goal in TBI is to reduce the intracranial pressure and prevent more cerebral edema. So you have to think in your head that which kind of fluids can I give them that will not worsen the cerebral edema or cause more fluid to go into the brain cell and worsen the cerebral edema. What fluids can I give them that will help to reduce the intracranial pressure? Now let's go through it, since it's selected or apply. Now, A says D5W at 100 ml per hour. We know that dextrose, 5% dextrose in water it becomes hypotonic in the body when it's metabolized. And what hypotonic fluids, they shift more fluids into the cell. So if you should give a patient that already have traumatic brain injury hypotonic fluids, if you should give them hypotonic fluids, that will cause more fluid to shift into the brain cell and worsen the cerebral edema. So that is why we are not giving them. So avoid hypotonic fluids in patients with TBI, traumatic brain injury, patients that have increased intracranial pressure, because hypotonic fluids will worsen the cerebral edema, will send more fluids into the brain cell, and will cause the brain cell to swell up like a hippo. Okay? Now, the next one also says 0.45 normal saline. This is also hypotonic fluids, and we are not using it in patients with TBI, patients with intracranial pressure. We don't want more cerebral, we don't want to worsen the cerebral edema. Okay? Now, 0.9 normal saline. This is good. Check. We will use 0.9 normal saline because why? This fluid stays in the intravascular space. They are not shifting into the cell to worsen the cerebral edema. So we'll give 0.9 normal saline, and it is often the go-to maintenance fluid in TBI patients. Go-to maintenance fluid with traumatic brain injury. So that is good. And the last one, 3% normal saline. 3% normal saline does what? This is hypertonic. And what do? They shift fluids. They shift fluids out of the cell and they shift fluids out of the cell. And that is what we want, because they have the patient have TBI, traumatic brain injury. There is some intracranial pressure going on, cerebral edema going on. This will help to shift out fluids out of the brain cell, and it will help to reduce the intracranial pressure and cerebral edema. And that is what we want to give them. So we are giving them C, 0.9 normal saline, and we are giving them D, 3% normal saline. Okay? Now let's move on. A patient in septic shock is hypertensive, 78/40, cold-morted and oliguric. Which initial fluid is best? A, lactate ringers bolus. B, 0.45 normal saline bolus. C, D5LR bolus. And D, 25% albumin bolus. Now the right answer is A, lactate ringers bolus. Now let me explain to you. See what's going on. A patient in septic shock is hypotensive. Now, what is septic shock? You want to know that before you can understand. Septic shock is life-threatening condition that happen when severe infection causes your blood vessel to dilate and leak, and this will lead to drop of your blood pressure. And this means the organs won't get enough oxygen and they start to fail. And that is why you see the patient is hypotensive, 78/40. Look at the signs and symptoms also. Cold-morted and oliguric, that is low urine output. This is showing signs of poor perfusion. So giving lactate ringer, which is LR, it is an isotonic crystalloid similar to plasma, which is a first-line choice along with normal saline for initial fluid resuscitation in shock. This will help to restore intravascular volume, because that is our priority in septic shock. Fluid volume resuscitation is a priority in shock. So giving lactate ringer is the best option. Now let's go through the next one. 0.45 normal saline. This is hypotonic fluids, and it will shift fluids into the cell. The fluids will not stay in the bloodstream, and this will worsen the shock, because we need the fluid volume to stay in the bloodstream, to stay in the intravascular space. And also hypotonic fluids, this will not raise the blood pressure. C says 5% dextrose in lactate ringer. Once 5% dextrose metabolites to become hypotonic, and we don't want to give them hypotonic fluids. That fluids will not stay in the bloodstream, it will not stay in the intravascular space, it will go into the cell, and that's not what we want. And D, 25% albumin bolus. That is not the first choice we should use, and it can be used later if the patient is still hypotensive but they are already fluid overloaded, but it cannot be initial fluid used. Also, I want you to know that 25% albumin bolus, it is too concentrated, it is too expensive, and it is not proven to be better than crystalloid in treating septic shock. Okay, so that leaves our answer to be A, lactate ringers bolus. Okay, now the next one says an older adult with chronic dehydration has sodium of 160, stable blood pressure, and no seizure. Which fluid is best to gradually correct hypernatremia? So normal sodium level is 135 to 145. This patient have 160, hypernatremia, high sodium level. A says D5W, B 0.9 normal saline, C 3% normal saline, and D, lactate ringer. And the right answer is A, 5% dextrose in water. Because these fluids will act as hypotonic in the body. When 5% dextrose is metabolized, it's isotonic in the bag, but when it's metabolized in the body, it becomes hypotonic. Hypotonic fluids contain high water, less salt concentration. So we need a fluid that will dilute the sodium. Okay? Because the patient have high sodium. So we need a fluid that will contain a lot of water, that would help to dilute that sodium. And that's why we are giving them hypotonic fluids, because it contains more water, less salt concentration. We don't want more salt, we want more water. Okay, now why not B, 0.9 normal saline? It is an isotonic fluid, and it does what? It contains equal amount of water and salt. We don't want more salt. And isotonic fluid does not lower sodium level efficiently. And if kidneys are unable to excrete the sodium, it might actually increase sodium level slightly. So we don't want that. C, 3% normal saline. Oh my God, these fluids or this solution contain very high salt, less water, and the patient already have high salt. You want to add more salt? No. And that is why we are not using hypertonic, 3% normal saline, which is hypertonic fluid. It contains too much salt. Okay? And D, lactate ringer. Remember I told you lactate ringers contain some electrolytes, and part of the electrolytes is sodium. So lactate ringer have some sodium in it, and the patient already have hypernatremia. You don't want to add more sodium. So the fluid you are giving will be fluids that contain very little salt, but more water to dilute the salt, the high salt the patient already have. Okay? Now the next question. You are preparing to transfuse packed red blood cell. Which IV fluid is compatible to run with blood? A, 0.9 normal saline. B, lactate ringers. C, D5W, and D, D5LR. And that's the right answer is A, 0.9 normal saline. I have said it before and I will say it again. 0.9 normal saline is the only IV fluid compatible with blood products. It is isotonic fluid and does not affect red blood cell. I need you to know that there is whole blood and there is packed red blood cell. What is whole blood? Whole blood means the blood, it still contains red blood cell, white blood cell, plasma, and platelets. And for packed red blood cell means in the whole blood, the white blood cell have been removed, the platelets have been removed, the plasma has been removed. The only thing left is the red blood cell, and that's what they are giving to these patients. Okay, now like I said, you give normal saline, which is the only IV fluid that is compatible with blood products. Okay, now let's go through the wrong ones. B, lactate ringer. Lactate ringers contain calcium, and calcium can cause the blood cell to clump up, to mold up, and that's why we are not using B. C, 5% dextrose in water. This is sugar plus water, and it can make the cell, red blood cell to burst. And D, 5% dextrose in lactate ringers. This contain dextrose, which is sugar, and lactate ringer, which have calcium. It can make the blood cells clump and burst. So only normal saline. Okay, now the next question. A patient with DKA has improved perfusion. Glucose is now 190, but ketones persist. Which fluid change is most appropriate? A, continue 0.9% normal saline. B, switch to D5 0.45 normal saline. C, start D10 W, and D, switch to 3% normal saline. Guys, and the right answer is B, switch to D5 0.5% normal saline. Now let me explain it to you. These patients, they have DKA, and in DKA they will experience high blood glucose. Now it says in the question, the glucose is now 190, which means they've already been given insulin to lower that blood glucose to 190, but ketones persist. Okay, now if you should give them B, switch to D5 0.45 normal saline. This is 5% dextrose in 0.45 normal saline in half saline. Dextrose contains sugar. Look, the sugar level is already below 200. And if they continue insulin therapy without giving more sugar, the patients risk hypoglycemia. So if you give them 5% dextrose in half saline, dextrose is sugar, that will, while the insulin is still trying to work on getting rid of the ketones, the 5% dextrose will help the patient from risk of hypoglycemia, from being hypoglycemic, because it is sugar. Because the insulin is still working to get rid of the ketones, and that's for the 5% dextrose. right? And they have normal saline, which is the 0.45 normal saline. That is water and sodium, and that would help to continue to correct dehydration. You know, in decay they will be dehydrated because of osmotic diuresis. So because there is still ketones, the insulin is still working. Give them 5% dextrose to prevent hypoglycemia, to keep the blood glucose from going down, blood sugar from going down. Okay, now let's go through the wrong ones. A says continue 0.9 normal saline. If you continue just 0.9 normal saline and the insulin is still working and their blood glucose is already below 200, it's 190, they will be hypoglycemic because the insulin is still working to get rid of the ketones, and you're only giving them normal saline. That will correct dehydration, but it will not help them from being hypoglycemic because there's no sugar and the insulin is continuing to lower the blood glucose, the blood sugar. Okay, and that's why we are not using only normal saline. And C says start D10W. D10W is too concentrated in glucose or sugar, which can lead to risk of hyperglycemia, which is what we are trying to correct, and that's why they are using insulin. So starting D510, which is 10% dextrose in water, which is very concentrated with sugar, is not needed in this stage. It is too much sugar. We are trying to lower the blood glucose. That's the indicator. And D, switch to 3% normal saline. This fluid contains high salt, less water. We are not dealing with hyponatremia here. We want to correct the blood glucose. This could worsen the dehydration and sodium balance. Now, let's go. A patient with diabetes insipidus is dehydrated and the sodium is 154. Blood pressure is 120/74. No shock, okay? Which fluids are appropriate to correct free water deficit? A, D5W. B, 5% normal saline. C, 0.9 normal saline. And D, 3% normal saline. And guys, the right answer is A, D5W, which is 5% dextrose in water. Now I want you to understand that the patient have high sodium. Normal sodium is 135 to 145. This is 154, hypernatremia. And we are looking for a fluid that have free water that will be able to help dilute the sodium and correct the hypernatremia. Okay, and that is why our answer is A, D5W. D5W, which is 5% dextrose in water, is isotonic in the backbone. Once it's infused in the body and it starts metabolizing, it turns to hypotonic. It's turn to free water once the sugar is metabolized, and this water will help to correct the sodium, to dilute the sodium slowly and correct the hypernatremia. And that is why we are using D5W. Okay. And it is perfect for patients that are not in shock, because as you can see, the vitals are stable. The vitals of this patient is stable. The blood pressure is 120/74. Okay, and there is no shock. Now let's go through the wrong one. And B is 5% normal saline. This is hypertonic fluids, high salt. The salt of this patient, the sodium level of this patient is already high. You don't want to give them hypertonic fluids that contain high salt concentration, low water concentration. That is hypertonic. So you want to give them something that have more water, less salt. So that is why 5% normal saline we are not giving is hypertonic and have too much salt, and we're trying to correct the salt. 0.9 normal saline contains equal level of water and salt. 0.9 normal saline does not or cannot be used to lower sodium effectively. D says 3% normal saline, the same thing. It is hypertonic, too much salt. It will actually even it will raise the sodium level, cause more hypernatremia, and we are trying to lower the sodium level. Okay, and that is why the best choice here is A, 5% dextrose in water. Okay, now let's go. A patient with acute pancreatitis, no shock, needs IV fluids. Which fluid is generally preferred early? A, lactate ringers. B, 0.45 normal saline. C, D5W, and D, 3% normal saline. And guys, the right answer is A, lactate ringers. Why? Lactate ringers is isotonic fluids, and this fluid will stay in the intravascular space. It will stay in the bloodstream and restore fluid volume safely. And it is good for mild, moderate pancreatitis without shock. Because as you can see, the patient is with acute pancreatitis, no shock. Now let's go through the wrong choices. 0.45 normal saline. This is hypotonic, and that is B, 0.45 normal saline. This is hypotonic, and you know what hypotonic fluid does? With hypotonic fluids, water moves into the cell, and this can increase risk of pancreas edema, because hypotonic fluids causes fluid to shift into the cell, and that's not what we want. In fact, B, C, and B and C, because they are both hypotonic fluids, they will do the same thing. They will shift fluid into the cell, and the patient will be at risk of pancreas edema, and we don't want that. And D is 3% normal saline, hypertonic. very concentrated, and this can worsen sodium and fluid balance. So it is dangerous in stable pancreatitis. That's why we are not choosing. So the best one that would, according to the question, would the best fluid that would be preferred early, according to the question, would be lactate ringers. Okay, now let's move on. Your patient's TPN is interrupted unexpectedly. To prevent rebound hypoglycemia, what should the nurse hang until TPN resume per protocol? A, D10W, B, 0.9 normal saline, C, D5W, and D, half normal saline. And guys, the right answer is A, D10W. This is 10% dextrose in water. What is dextrose? Sugar. Look at what's happening here. The patient is on TPN, total parenteral nutrition, and it's interrupted unexpectedly, suddenly, right? That means the nutrition stops suddenly. Now, to prevent rebound hypoglycemia, because the TPN is no longer running, give them 10% dextrose in water, right? Which is A. Why? Because 10% dextrose in water contain high sugar level. So to prevent hypoglycemia, we are giving them another fluid until the TPN resumes. We are giving them another fluid that can act like the TPN, that contain high sugar. Now let's go through the wrong one. B says 0.9 normal saline. This is just sodium chloride. There is no sugar in it. We are looking for something we'll give them that will prevent hypoglycemia. So that's why that is wrong. Now, C say D5W, which is 5% dextrose in water. It might not provide enough glucose for patients that are receiving if their TPN is high in glucose. It will not provide. And the last one is this. D says half normal saline. It's just normal saline, sodium chloride, no sugar in it. We are looking for fluids that will prevent hypoglycemia. Okay? And the very last one, guys, I'm glad we made it. I hope the review is not boring. The very last one. And thanks for staying till the end. I hope you understand this. Now let's go through the very last one. A patient has serum potassium 6.1 and ECG changes. Which IV fluid order should the nurse question? Which should you question? A, lactate ringers at 125 ml per hour. B, 0.9 normal saline at 125 ml per hour. C, D5 0.45 normal saline with 20 potassium chloride. And D, D10W at 50 ml per hour. And this is select order. And this is a select order apply. And the right answer is A and C, guys. What should you question? This patient potassium is already high, right? If any of this fluid is ordered for this patient that is already already have high potassium, because the high potassium is already affecting the heart, which of these fluids should you order? Should you question as the nurse? You should question lactate ringers and C, D5 0.45 normal saline. Why? Lactate ringer contains some electrolytes, and potassium is part of the electrolytes that is contained in lactate ringers. The patient's potassium level is already 6.1. Normal potassium is 3.5 to 5. Now, if you give them lactate ringer that also contain potassium, you are adding to the potassium level. The EKG changes shows that the high potassium is already affecting the heart. Why should you add to it? So that's why you shouldn't give them lactate ringer, because it will worsen the hyperkalemia the patient is already experiencing. Okay, so you should question that. And C, why should you question C? Look, it says D5, which is 5% dextrose in half normal saline with 20 MEQ potassium chloride. They already have hyperkalemia. You want to add more potassium to it. Cardiac arrhythmia, cardiac dysrhythmia is waiting for your patients. Cardiac arrest is waiting for your patients. So you are not doing that. And that is why we are questioning that order. The orders that are good for them, which is B and D, is 0.9 B, which is 0.9 normal saline at 125 ml per hour. There is no potassium in this, and it is safe, and it can help to flush out the potassium via the kidney. Okay. And the last one says D10W, which is 10% dextrose in water, which is sugar. There's no potassium in it, and this can be used with insulin to help shift potassium back into the cell. All right, guys, thank you for watching till the end. Bye.